All right, welcome to our explainer on positional testing. This is the fourth video in our 5-part series on the bedside vestibular exam, and today we are tackling the single most common and, the most treatable cause of vertigo out there.
So we're going to be focusing on the specific techniques for diagnosing benign paroxysmal positional vertigo, or BPV. Look, mastering these skills isn't just helpful, it's a total game changer. It means you can actually cure a patient's vertigo a lot of the time before they even leave your clinic.
Let's really dive into this quote, because it's the core message for today. The ability to cure this incredibly common condition in just one visit? Well, that doesn't come from just knowing a test exists. It comes from mastering how you perform it. Precision. It's everything.
So what are we really dealing with here? BPV can account for nearly a third of all the patients you'll see in a dizziness clinic. It is that common. And for this specific condition, getting the diagnosis right isn't just the first step. It is the only path to a cure.
Okay, so before we get into the how of the tests, we really need to understand the why. I promise, the logic behind every single maneuver becomes so much clearer once you get what's happening mechanically inside the inner ear. And it all starts with these tiny little misplaced crystals.
These little guys, these are the culprits. When these autoconia break free and start drifting around in the canals, they totally disrupt the normal fluid dynamics. They're essentially sending a false signal to the brain that you're moving when you're not. So our job is to figure out exactly which canal they've wandered into. And here's where it gets really interesting. A whopping 85% of all BPV cases involve just one location, the posterior canal. Now, this is fantastic news for us as clinicians, right? It means one specific test, the classic Dix-Hallpike, is going to successfully identify the vast majority of our patients. Now, let's peel back another layer. Are those crystals just floating around freely, or are they actually stuck to the motion sensor, the cupula? This distinction is absolutely crucial. Why? Because it changes the eye movement, the nystagmus, from a brief, tired-out event to something persistent and lasting. And that one detail tells us exactly which treatment to use. Okay, so let's get right into the masterclass on the Dix-Hallpike. This is the definitive gold standard test for that 85% of BPPV cases that happen in the posterior canal.
Listen, every single step here is deliberate. It's designed to isolate one canal. That initial 45-degree head turn, that's not random. It lines up the posterior canal perfectly with the pull of gravity. If you're off by even 10 degrees, the test just isn't clear. The rapid movement down is what gets those crystals tumbling. If you go too slow, they won't move enough to cause a reaction. And that head extension at the end maximizes the stimulation. See? Technique is everything.
So what exactly does a positive test look like? Just think of it as a 4-point checklist. For a classic textbook diagnosis, you have to see all 4 of these. First, there's a delay, a latency, before it starts. Second, the direction has to be right, upbeating and torsional. Third, it's got to be brief, under a minute. And finally, it has to get weaker with repetition. That's fatigability. A high-confidence diagnosis means you've put a check mark next to every single one of those.
Okay, but what happens if the Dix-Hallpike is negative, but you still have a strong suspicion that it's positional vertigo? Well, your very next step is to test for the second most common type, horizontal canal, BPPV.
Now for this test, the patient's already lying down. You elevate their head about 30 degrees, and that brings the horizontal canal right into the plane of movement. Then it's just a simple, brisk head rotation to each side, while you watch their eyes very, very carefully for any horizontal nystagmus. This is where just watching the eyes gives you all the answers. It's brilliant. If the nystagmus beats towards the ground, we call that geotropic, it tells you the crystals are free-floating. And the side with the stronger nystagmus is your culprit. But if it beats away from the ground, that's apogeotropic, it means the crystals are stuck, and it's actually the side with the weaker nystagmus that you need to treat. That one observation tells you the pathology and exactly where to treat.
And this brings us to what might be the most critical point of this entire explainer. How do you know with confidence that this is a benign issue in the inner ear and not something much more serious happening in the brain?
Knowing the answer to this question, well, that's what separates a good clinician from a great one. It's absolutely key to safe and effective practice, because sometimes a central issue can be a very convincing mimic of BPPV. Think of this table as your diagnostic safety net. I want you to focus on that right-hand column. Any of those signs should immediately make you pause.
nystagmus with no delay, that lasts longer than a minute or is purely vertical. But the biggest red flag of all is the lack of fatigability. If that response is just as strong the second or third time you test, that is a major red flag for a central cause, and that patient needs urgent neuroimaging.
So look, the crucial point to take away is this. Learning these patterns isn't just about figuring out how to diagnose BPPV. It is equally, if not more important, about developing that pattern recognition to know when the signs just don't fit and when you need to start investigating for something else entirely. In our final explainer, we're going to bring all of this together. We'll combine positional testing with the HINTS exam and our other bedside tools into a structured 5-minute protocol. Then we'll apply it to a couple of real-world cases. Honestly, this is a skill you absolutely have to have in your clinical toolkit.
Thank you so much for watching. To access more clinician resources and learn more about dizziness, vertigo, and imbalance, please visit our website. And hey, if you found this series helpful, please don't forget to subscribe and leave us a rating.